So we'll go ahead and get started. My name is Jody Novotny. I'm a volunteer with ThyCa, and I'm just here to help facilitate. Again, this is session 154. The title is Monitoring of Low and Intermediate Risk Papillary and Follicular Thyroid Cancer Patients in the First 5 Years After Initial Treatment. And I'm honored to introduce Dr. Stephanie Fish, who will be presenting today. I'm going to go ahead and read Dr. Fish's bio, and then I will turn it over to her. And I'll also just say that we are going to hold questions until the end of the presentation. Again, we have Dr. Fish here with us today. She is an endocrinologist at Memorial Sloan Kettering Cancer Center in New York. Dr. Fish earned her medical degree from NYU School of Medicine and completed her training in internal medicine and endocrinology at the University of Pennsylvania. Dr. Fish is currently running a clinical trial through Memorial Sloan Kettering Cancer Center titled Study of Resistance to Thyroid Hormone After Long-Term Exposure in People with Thyroid Cancer. And with that, it's my honor to turn it over to Dr. Fish.
Thank you so much. I'm really excited to be here today and excited to talk about thyroid cancer. And I'm going to talk for a bit and give you some background and information, and then I'm always happy to answer any questions that come up. I guess I'm just going to start. There we go. So I'm going to start with a case and sort of to talk about how we monitor our patients with thyroid cancer and sort of explain to you the tests that the doctor may order, why we're ordering these tests, and what our approach is and how we make our next decision based on the results of each test. So I'm just going to start with a very typical patient that I said I'm focusing on low and intermediate risk patients with well-differentiated thyroid cancer, which is either papillary thyroid cancer or follicular thyroid cancer, the two most common and typical types of thyroid cancer. And we'll start with this 32-year-old female. And I'm not going to start with the whole initial evaluation. We're going to talk about the monitoring. So this is a diagnosis that's already been made. She was treated with a total thyroidectomy, which showed a 1.1 centimeter classic papillary thyroid cancer, the most common type of thyroid cancer. The tumor did not have any vascular invasion, no invasion into the bloodstream, no extrathyroidal extension, so no extension outside of the thyroid, and the surgical margins were negative. So the tumor was completely contained within the thyroid itself. In addition to that primary tumor, we say the bigger tumor, there was also a small focus of what we call micropapillary carcinoma that measured just 0.1 centimeters or 1 millimeter in size. And it's quite common in our patients with thyroid cancer that they may have a main tumor and then some little tiny tumors. Doesn't really change our approach to treatment or overall prognosis, but it's something that we do see quite commonly. And then the surgeon did take out 2 lymph nodes from right behind the thyroid, and one of those lymph nodes had a tiny focus of thyroid cancer. We call this a micrometastasis. It measured just 0.1 centimeters, and it had no extranodal extension, so no extension outside of that lymph node. So she had her surgery. After surgery, she started treatment with levothyroxine thyroid hormone at a dose of 0.1 milligrams daily. And generally, we recommend about 8 weeks after surgery is when you do your first set of labs. And at 8 weeks after surgery, her TSH was 0.4, which is just a little bit low, just below the normal range, and a free T4 of 1.4, which is in the normal range. Thyroglobulin, which is a blood test we use as a marker for thyroid cancer, I'm going to talk a little bit more about that later, was low at 0.1. Thyroglobulin antibodies less than 0.9, which is negative. So this is sort of the starting point. This is typically at the point where I will see a patient for the first time, about 8 weeks after surgery, had their first set of labs, and they're going to come to see me. And when I see a patient, sort of my starting point is we think about two things. We think about what stage this thyroid cancer is, and the staging system really is meant to predict overall survival from thyroid cancer, overall prognosis. And then the second part, we think about what's the risk of recurrence? What's the chance that the thyroid cancer can come back? So when I see a patient, I'm going to think about both of those things. And right now I'm going to go through sort of our categories of how we think about it and how we put people into those different categories. Based on the title of my talk, when I say a low and intermediate risk thyroid cancer patients, I'm going to focus in my surveillance right now on this talk on those patients at low or intermediate risk for recurrence. So these are patients who have a low risk of the thyroid cancer coming back. So just to start, so the first thing we think about is the staging system. And like I said, that's going to predict overall survival. And staging for thyroid cancer is quite unique in that I think it's the only cancer where the staging is different depending on your age at diagnosis. So for thyroid cancer, there's a staging system for young patients, which is considered less than 55, and a different system for older patients, which is considered 55 or older. And so within the young patients, so this is the staging system for young patients less than 55, there's just two stages, stage 1 and stage 2. And the reason for that is that staging is meant to predict survival. Young people with thyroid cancer in general have excellent long-term survival, respond very well to treatments, and generally do well after treatment. And so there's not stage 3 and stage 4 because those are the stages more associated with higher rates of death from thyroid cancer. And we just don't see that in our younger patients. So most young patients are going to be stage 1. That's anybody with thyroid cancer in the neck, in the thyroid or in lymph nodes in the neck, but only in the neck. That's always going to be stage 1. And then stage 2 are those patients who have their thyroid cancer that has spread to the lungs or spread to the bone, move somewhere outside of the neck. That would be stage 2. Stage 1, 99% 10-year overall survival. Stage 2, when there is metastatic disease outside of the thyroid, overall survival does decrease. And then in those older patients over 55, now there are 4 stages more typical of a cancer staging system for patients over 55. Again, stage 1 is small tumors, less than 4 centimeters, confined to the thyroid. So no lymph node metastasis there for stage 1. Stage 2, larger tumors over 4 centimeters or any lymph node metastasis, any lymph nodes involved, that's going to be a stage 2. And even if there's a little bit of extension into sort of some of the muscle tissue in the neck, still going to be within stage 2 in the older patients. Stage 3 is going to be really any tumor, but with a lot more extension. It's going to extend into the larynx or the trachea or the esophagus. It's going to involve the recurrent laryngeal nerve, have issues with the voice afterwards. So this is a more invasive tumor, but still within the neck. And then stage 4 is really when we start to get these distant metastatic disease or very invasive tumors. So, and again, these stages are meant to predict survival, where stage 1 and stage 2 survival, 95 to 99%. Excellent long-term survival with these lower stages. Into stage 3, it does drop to around 60%, but really it's the stage 4 patients which have a poorer overall long-term prognosis with a 10-year disease-specific survival of about 30%. So that's sort of our starting point as we're going to look and stage the thyroid cancer. And again, in the talk, I'm going to focus on really those that are going to be stage 1 and stage 2, because that's going to go along with our low and intermediate risks of recurrence. Those older patients with 3 and 4 are those that are going to have a much higher risk of recurrence over time. So I'm going to shift now. So here's the charts and sort of the categories of how we think about this risk of recurrence. And this is really something established by the American Thyroid Association in guidelines that have been put out to regarding the treatment of thyroid cancer. And so we say ATA for the American Thyroid Association, low risk for recurrence for the thyroid cancer coming back. We're going to say papillary thyroid cancer with no distant metastasis, so nothing in the lungs, nothing in the bones, nothing that's spread outside of the neck. All the tumor has been removed at the time of surgery, and there's no invasion into the tissues or structures in the neck, so no extra thyroidal extension. There's no signs of aggressive histology, which I'm going to review in a second. So it's more the classic papillary or the follicular variant of papillary, and not the aggressive types of papillary thyroid cancer that can be like the tall cell variant, hobnail variant, or columnar cell variant. If radioactive iodine is given, then no uptake of that iodine outside of the thyroid bed on the post-treatment scan. So no signs again of thyroid cancer having spread, no invasion into the bloodstream, and either no lymph nodes involved, or if there are lymph nodes involved, less than 5 lymph nodes, and tiny lymph nodes, less than 0.2 centimeters. So even you can be low risk and have a lymph node metastasis as long as it's a really tiny lymph node metastasis. So that's sort of the papillary thyroid cancers. Also low risk are the encapsulated follicular variant of papillary thyroid cancer. And the follicular thyroid cancers that are intrathyroidal, these tumors are typically encapsulated with some capsule invasion, and then minimal, if any, vascular invasion, and minimal is considered less than 4 foci. So those patients with follicular thyroid cancer where there's minimal invasion, those are going to still be low risk for recurrence. And then the last group in this category are patients with papillary microcarcinomas. So these are tumors less than 1 centimeter in size, either a single focus or multiple foci, but all contained within the thyroid. No extra thyroidal extension, no invasion into the bloodstream. Even if there's lots of little tumors, if they're all contained within the thyroid, that's considered someone who would be low risk for recurrence. So that's the first group we're going to talk about. And then the second group is the intermediate risk. And now this is going to be slightly more advanced in their thyroid cancer. So these are patients, again, with papillary thyroid cancer who might have some microscopic invasion into the soft tissues, a little bit of that extra thyroidal extension. They may, if they get radioactive iodine, they may have a little bit of uptake in neck areas on the post-treatment scan. Still uptake, still not outside of the thyroid, but maybe a little bit of a more involved tumor. This is where those aggressive histologies come in. The papillary thyroid cancer tall cell variant, hobnail variant, or columnar cell variant. These are types of papillary thyroid cancer that can sometimes behave more aggressively. Vascular invasion or invasion into the bloodstream. And now again with the lymph nodes, either greater than 5 lymph nodes, but all lymph nodes less than 3 centimeters. So there's more lymph nodes, but they're not very, very big. That's going to be intermediate risk. And then for these papillary microcarcinomas, if you do have a little bit of extra thyroidal extension, that's going to push you into the intermediate risk category. So overall, these low and intermediate, people who fall into the low and intermediate risk category is what I'm going to try to focus on. But I just wanted to give you all the definitions so that you knew what we were talking about. So this is what would categorize as a high risk patient, meaning high risk of recurrence based on the initial pathology at the time of diagnosis. So this is going to be tumors that are invading into the soft tissues, perhaps even aren't able to be removed entirely, or need to take out soft tissues or muscle to remove the whole tumor. If there are distant metastases, lung nodules, bone metastases, that's going to be high risk. If the thyroglobulin level after surgery, that blood test that we use as a marker for thyroid cancer, if it's elevated, suggestive that there would be some metastasis, that's going to put you in a high risk category. If you have lymph nodes, especially large lymph nodes larger than 3 centimeters, And then for follicular thyroid cancer, those with extensive vascular invasion, more than 4 foci. So that's one thing that's kind of interesting with the follicular thyroid cancer. You're either low risk because you're minimally invasive, or you're high risk because you have extensive vascular invasion. So there's really no follicular thyroid cancers in that intermediate risk category. It really kind of splits into low risk or high risk for recurrence. And so that's sort of our starting point. So again, I'm just going to come back to this patient that I presented. So I see her for the first time, and my first thing that I'll talk about is that she's going to be a stage 1 thyroid cancer. She has a small papillary thyroid cancer contained within the thyroid, 1 metastatic lymph node, but it's tiny. So she's going to fall into that, and she's going to be a stage 1 and low risk of recurrence right from the start. So that's my starting point when I'm seeing her, to kind of figure out what type of testing is necessary next. And so that's what I'm going to think about. And so there's 2 real things that I think about when I'm first seeing a patient. I figure out the stage, I figure out the risk of recurrence, and then I think about how much thyroid hormone medication do they need? What's my goal for their TSH level? And then I think about whether or not they need additional treatment with radioactive iodine. So radioactive iodine, I'm sure many of you know, is a treatment that we use for thyroid cancer. The thyroid uses iodine to make thyroid hormone, and we take advantage of that fact. We can attach radioactivity to iodine. You take it in the form of a pill. Any little bit of thyroid tissue can take up the iodine, and the radioactivity will destroy it. In many years ago, everyone with thyroid cancer had surgery, got radioactive iodine. It was sort of a one-size-fits-all approach. And that's really changed over the past few years. And we really now have tried to do evidence-based decision-making and recognize that everybody doesn't need radioactive iodine. And sort of there are patients where the risks to getting radioactive iodine really outweigh the benefits. So, and specifically in those patients with stage 1 thyroid cancer, studies have shown really no benefit to radioactive iodine. So sort of when I'm seeing a patient and thinking about the stage, thinking about the risk of recurrence, when I see a stage 1 low risk patient, radioactive iodine is generally not going to be on the table, not going to be something that I recommend. On the other extreme, stage 3, stage 4, high risk of recurrence, pretty standardly, they're almost always going to get radioactive iodine and some additional treatment after surgery. And, the intermediate risk patients, they're always the challenge, because based on guidelines, it's sort of, the answer is there's selective use of radioactive iodine. So in those patients, when you fall into that intermediate risk category, it's really a decision between you and your doctor whether or not you would really benefit from radioactive iodine. Generally, in patients who do have vascular invasion, or the tumors invaded into the bloodstream, or significant lymph node disease, while they still may categorize as intermediate risk, those are the patients that I would typically recommend radioactive iodine to. Whereas if there's maybe only 1 or 2 lymph nodes and they're not that large, while it may pull you into that intermediate risk, probably might watch without the radioactive iodine treatment. So that's where there is a little bit of a decision making between you and your doctor, and just understanding sort of the options in that area. So that's a bit about sort of my radioactive iodine decision, and then the thyroid hormone decision. So the thyroid medication, what we really are generally doing is titrating or adjusting the dose based on the TSH level. So TSH stands for thyroid stimulating hormone, and it's a hormone that's made in the brain in the pituitary, and it regulates your thyroid hormone levels, or it monitors or adjusts based on your thyroid hormone levels. In general, with thyroid cancer patients, TSH, it's a hormone that's a stimulating hormone. If you have high levels of TSH in your blood, theoretically, that could stimulate any thyroid cells or thyroid cancer cells to grow. And so with our thyroid cancer patients, we don't want anything that could stimulate their cells to grow. So we typically give a dose of levothyroxine or thyroid hormone to keep the TSH low. And for most of my thyroid cancer patients, I'll keep the TSH low at least for the first year after the diagnosis. How low depends a little bit on your lab and what your normal is for your assay, but where I work, normal for TSH is 0.6 up to about 4.7, I think. So when I say I'm keeping it low, I typically try to keep it between 0.1 and 0.5. That's generally my goal for about the first year of surveillance. And then I may adjust it, and I'm going to talk a little bit more about that as we keep going through the talk. But so typically we're going to give a dose, keep that TSH low for the beginning, see how you do, and then that goal may change over time. So that's our initial therapy, thyroid hormone, decision about radioactive iodine. And then we say we're going to monitor our response to therapy. You've had your surgery, you're on the levothyroxine, maybe you got radioactive iodine, maybe you didn't get radioactive iodine, and we just have to see what happens over time. Time is our friend with thyroid cancer. The longer we watch, the more we watch, we get a better sense of how each individual's tumor is behaving. And the main tests that we do as part of our monitoring of response to therapy is blood work, where we monitor that thyroglobulin level, and imaging studies, generally neck ultrasounds. So thyroglobulin has already come up quite a bit, and so thyroglobulin is a protein. It's made by normal thyroid tissue, and it's made by thyroid cancer. If all your thyroid's been removed and all the cancer's been removed, that thyroglobulin level should be quite low. It might not be zero, but it should be very, very low. If at any point in time the thyroglobulin starts to rise or become elevated, that's a marker to me to say there could be something going on from a thyroid cancer standpoint, and that's something that we need to investigate and watch for. So that's where the thyroglobulin becomes an important part of our surveillance. We typically measure it initially about 8 weeks after surgery, generally every 6 months for the first year. If everything looks clear at that point, at least once a year after that. And we use that as our to monitor as our blood test monitor. And then the imaging, again, typically we use neck ultrasounds. There are other imaging studies that can be done, radioactive iodine scans, CAT scans, MRIs. Most of the time that's not necessary, especially in a patient with a low or intermediate risk thyroid cancer. Ultrasound is by far the most sensitive test to really look at the neck. If thyroid cancer should ever recur, by far the most likely place is locally in the neck. So the ultrasound looks at the bed where the thyroid used to sit. It looks at the lymph nodes in the neck, and these lymph nodes are fairly superficial. And so ultrasound's typically the best way to really identify them. And there are specific features that you can see on ultrasound that you can't really see on a CAT scan, and you can't necessarily see on an iodine scan, so that the ultrasound ends up really being the best test to look and monitor the structures in the neck and see if anything looks suspicious. And so typically both of these tests, thyroglobulin and ultrasound, we do about every 6 months for the first year, once a year after that for that total of 5 years. There's no signs of disease after 5 years. We typically will not continue with yearly ultrasounds and maybe do an ultrasound every 3 to 5 years, depending on the situation. But we'll always do yearly blood tests because you need to monitor the thyroid hormone levels and the medication dose anyway. So we do typically keep the blood work on a yearly basis, but the ultrasounds and imaging not as frequently after that 5-year mark. And so so that's what the testing that we're doing. And then the next thing I'm going to talk about is sort of how we interpret those test results. And we have sort of, again, categories, just like we had that ATA, low risk of recurrence, intermediate risk of recurrence, and high risk of recurrence. Now we have 4 categories that tell us about the response to therapy. How have you responded to the treatments that we've done, whatever treatments we've decided are most appropriate? And so here's just an example. Here we have testing 3 months or about 8 weeks after treatment, the 6 months and the 12 months. So we measure thyroglobulin. We measure always, when we measure thyroglobulin, we always measure thyroglobulin antibodies at the same time. Some people have antibodies against the thyroglobulin from underlying autoimmune disease or Hashimoto's thyroiditis. And when you do have antibodies, the thyroglobulin level is less accurate. So we always measure those two together because we need them both to interpret the results. But if we have this type of a patient, thyroglobulin super low, antibodies negative, at 6 months, thyroglobulin remains undetectable, ultrasound with no suspicious findings, and even at a year now, a year after surgery, everything is negative. We say that's a person who's had an excellent response to therapy. No evidence of disease, everything looks clear. On the other hand, sometimes we see this. After surgery, the thyroglobulin is still detectable at 15. 6 months, thyroglobulin still detectable, although a little lower at 9. Ultrasound doesn't show any suspicious findings. And now even at a year, the thyroglobulin continues to decrease, but it's not undetectable and the imaging remains negative. So this is a category, there's persistent thyroglobulin, nothing suspicious on imaging, and we call this biochemical incomplete. So we still are seeing signs of thyroid tissue or thyroid cancer in the bloodstream, in the biochemistry, but we're not seeing any structural disease. We're not seeing anything on the imaging study. So that's our next category. Persistent thyroglobulin, nothing on the imaging. We say a biochemical incomplete response to treatment. And I'm going to get to what we do when we see that. And then here, this I will say is not typical in our low and intermediate risk patients, but sometimes after surgery, the thyroglobulin is still detectable. Then 6 months after surgery, thyroglobulin is going up. We see some abnormal lymph nodes on the ultrasound. They're small, so we still watch. At a year, thyroglobulin's even higher, imaging abnormal lymph nodes. This we say is now structural incomplete. There's still disease there. This is someone where we need to do more treatment. We haven't gotten all the thyroid cancer. There's persistent disease, structural disease that we can see. And this is a patient where they would likely need more surgery, certainly more additional treatment with these types of results. Again, this is not a typical result in someone who's in low or intermediate risk of recurrence, but I'm just kind of giving the overall picture. And this is our last picture. This is the patient with those positive thyroglobulin antibodies. So now thyroglobulin may be undetectable, but we've got these positive antibodies, which makes it harder to interpret. As we follow over time and add some imaging on ultrasound, maybe there's a little nodule in the bed, an indeterminate or a prominent lymph node that's not clearly suspicious. It's not a definitive answer. It's not definitively bad, but it's also not 100% clear. And in that situation, we say this is an indeterminate response to therapy. This doesn't mean that there's thyroid cancer there, but there's still a chance that there's thyroid cancer there, enough that we can't say it's excellent. We can't say it's bad, but it's sort of in the middle. And we just use the term indeterminate. And generally, this is a situation where we keep watching and monitoring to see if things move in one direction or the other over time. So sort of as we do these surveillance tests throughout time, each time we get the results, we again think about these different categories to allow us to figure out what the right next step is. And one thing to keep in mind is that a patient can move from one category to another. So this patient here who's biochemically incomplete, if the next test, suddenly the thyroglobulin that had decreased to 5 goes down to 0, and the ultrasound's negative, we shift them over to an excellent response. So it's this is based on what's going on right at that moment, and you can move between categories as testing happens over time. And so again, I'm just going to come back to that initial patient, this 32-year-old woman with low-risk papillary thyroid cancer, and 1 year after her surgery, her TSH is 0.4, right in that range of 0.1 to 0.5 that I said I wanted. Thyroglobulin's undetectable, antibodies are negative, and there's nothing suspicious on her ultrasound. No nodules in the bed, no abnormal lymph nodes, she has had an excellent response to therapy a year out from her surgery. So what do we do now? And so the key here, so this is where how we manage and what tests we order depends on how the patient is doing, how you're doing, how you've responded to your treatments. So someone who's had an excellent response to therapy, the risk of recurrence now drops even further to 1 to 4%. It's not zero, but it's very, very low. Risk of death is less than 1%. And we may decrease now the intensity of our TSH suppression and the frequency of our testing. Now we may allow that TSH to go into the low end of normal, more between 0.5 and 1. And we can certainly test maybe once a year, certainly not every 6 months. And maybe we don't have to do ultrasounds every time. So if you've had an excellent response to therapy, your surveillance will be a little bit less frequent. On the other hand, if you fall into that biochemically incomplete category, like I said, 30% of the time, the thyroglobulin just goes away with time and you shift to excellent responses. So that's definitely something that's seen. But in that biochemically incomplete, as we follow over time, about 20% of people will eventually develop structural disease. Eventually, the imaging will show something abnormal and they may need additional treatment for their thyroid cancer. Still in this group, a very, very low risk of death. So this is still this is cancer that's still very, very treatable, but may require additional treatment after the first surgery. And so as long as the thyroglobulins and the antibodies are stable or even decreasing over time, we just observe. We do ultrasounds. We may do a CAT scan of the neck. We may do additional imaging, but we just watch and monitor. But especially if the thyroglobulin starts to go up or the thyroglobulin antibodies start to develop or go up, then we're going to be a little more aggressive in doing additional testing to try to see if there's any structural disease. The structural incomplete, those patients who have their initial treatment, their surgery, likely their radioactive iodine, and still have signs of disease, this is where we sometimes end up with patients who have persistent disease, have thyroid cancer that we can't treat completely, and there's a little bit of thyroid cancer left behind. And this is the group where, may need more advanced treatments, may need systemic therapies or redifferentiation therapies that I know there's sessions on during this weekend. But these are the patients who could potentially die of thyroid cancer depending on responses to treatment. So these are patients who will need additional treatment, who's going to need additional testing and likely more frequent follow-up and monitoring. And then that last group, that indeterminate group, again, many of these patients just stay the same, 80% just stable without any progression and just live in that indeterminate category. Some patients who are indeterminate will go to excellent and the antibody levels will go away over time, the thyroglobulin antibodies. Once the thyroid's been removed, the body doesn't have that stimulus to produce the antibodies anymore, but it takes years for them to go away. So some of the people in indeterminate will eventually get to excellent. About 20% will eventually develop structural disease. So it is possible that there's something hiding, and with close observation and monitoring, we'll see that over time. Again, very low risk of death in this group, but generally we'll keep the TSH a bit suppressed. We'll continue with regular imaging to keep an eye on what's happening over time. And this is actually my last slide. So this is just a chart that kind of explains sort of this approach to the TSH suppression, to keeping that TSH low. And again, as you see, it's based on how a patient has responded to therapy. So generally that first year, we don't know how anyone's responded till we really have a year of data. So we generally keep the TSH 0.1 to 0.5 in most of our thyroid cancer patients for the first year. But if after the first year you fall into that excellent response to therapy, not necessary to really suppress the TSH, and we can let it come up to 0.5 to maybe up to as high as 2. So in those excellent responses, we'll let that TSH normalize. And the indeterminates, most indeterminates we're going to keep with a little bit of suppression, that 0.1 to 0.5. But if you've got an indeterminate response and you've got other medical issues that can make it more risky to keep the TSH suppressed, then we may allow a more normalization of the TSH. This is especially in patients with atrial fibrillation and abnormal heart rhythm, which can be much worse in the setting of hyperthyroidism. And so in a patient with atrial fibrillation, we'll generally allow the TSH to normalize. In someone with significant osteoporosis or older age, we may pull back a bit on the TSH suppression in that indeterminate group. In the biochemically incomplete group, if they're young and otherwise healthy, we'll typically keep fairly significant suppression. In those who have maybe, some symptoms from too much suppression, we'll try to keep the TSH between 0.1 and 0.5, and only in the biochemical incompletes in the setting of someone with atrial fibrillation, that's the only time when we would allow the TSH to come into the normal range. And then those patients structurally incomplete, persistent disease and significant disease, we do keep the TSH suppressed, often even below 0.1, much more suppressed to try to prevent growth and progression of the disease that we know is already there. So that's sort of our, what a doctor will be thinking about as we look at the different test results, how we may monitor the synthroid or levothyroxine dose, and what types of testing we're going to order to kind of watch and monitor over time. And with that, I'm going to stop and open it up to questions, and we will go from there.
What is the difference between the predicted 10-year and the published 10-year stats that you shared?
Yeah, so it's just when they made these decisions, they kind of guessed what it would be, and then they used data to actually look at it. So the published is just the more accurate number. The predicted is just what was thought to be, what they thought might be the answer.
How is invasion in the bloodstream measured? You mentioned that a couple of times.
Yep, so that's based on the pathology report. So the pathologists will, they look at when the thyroid's taken out and they slice it into lots of slices and look at it under a microscope. They're looking for invasion, when the vascular invasion or blood vessel invasion is invasion into the blood vessels in the thyroid itself. So that's where we're looking at it. And so we're seeing if the tumor has spread into the blood vessels that were removed from within the thyroid.
And great. What does it mean for, what does papillary with follicular variant mean?
So this is just, again, these are results that are based on the pathology. So papillary thyroid cancer is primarily determined based on the cancer cells, the nucleus of the cancer cells. There are certain changes within that nucleus that are typical of papillary thyroid cancer. So that's sort of the nuclear features give you the diagnosis of papillary thyroid cancer. And then we look at how their structure, what the structure of the tumor is. A classic papillary forms these little papillae, little finger-like projections, and that's a classic papillary. A follicular variant of papillary, the nuclear features are still that of papillary thyroid cancer, but the tumor cells form these little follicles or circles within the tumor itself. The tall cell variant, that more aggressive type, the cells have the same nuclear features, but these cells are longer when they look at them under the microscope. So these are all different features that are determined by a pathologist based on looking at the tumor cells under a microscope.
So next question, should thyroglobulin be 0 for post-thyroidectomy patients? And what is the time frame to get to 0 or a number that is negligible?
So in patients who've had all of their thyroid removed, the thyroglobulin will be low, but it may not be 0, especially if you don't get radioactive iodine. If you've had all your thyroid removed and you get radioactive iodine, then ideally the thyroglobulin will go to 0, although sometimes it'll be 0.1 or 0.2, and that's not a significant number and it's fine. If you've only had half of your thyroid removed to treat your thyroid cancer, which we often do now in smaller tumors or less aggressive tumors, if you still have half a thyroid, you're going to produce thyroglobulin. That half a thyroid will always make thyroglobulin. So in someone who's had just a hemithyroidectomy, In someone who's had just a hemithyroidectomy, the thyroglobulin will never get to 0. In someone who's had a total thyroidectomy, it may get to 0, but it may stay just low and detectable. Someone who's had a total thyroidectomy and radioactive iodine is the most typical time when you will see it get to 0.
And someone asked specifically, this is related, if 0.5, 0.5, 0.6 thyroglobulin would be considered low.
Yes,
And
it
not
would be
significant.
considered low. It's not 0. If that's where it's been since surgery and it's always 0.5 and 0.6 and not changing, then I say it's stable and absolutely fine and sort of your baseline. And I'd be looking for really a change over time if it was started to go up. There's always a little variability. So if it's 0.5, it may be 0.6, and then it may come back down to 0.5, and then it may be 0.4. So it's not a number that's going to be exactly the same every time it's measured. When we say a change, we're typically thinking about it doubling. So if it's always been 0.5 and suddenly it's 1, that's a more significant change, where if it's 0.5 and 0.6, that's a fairly common type of change.
Is the diffuse sclerosing variant in the same risk group as the other referenced variants?
So the diffuse sclerosing variant is a variant that's more typically seen in young patients with thyroid cancer. It is a type that often spreads to lymph nodes, so it's quite common to have the diffuse sclerosing variant present with metastatic lymph nodes at presentation. But it typically responds quite well to treatment, to surgery and radioactive iodine. So generally very good long-term prognosis, but typically presents in a more advanced stage. It's hard to say if there's that lymph node metastasis, that they often will be in that intermediate and in the category of intermediate risk of recurrence over time.
This person wants to know what to expect, had surgery 2 years ago with lymph node dissection in L6, minimal external.
Extrathyroidal extension, I see it. Okay,
Yep.
I got it. Had
Yeah.
RAI.
Yep.
Okay, so had RAI, thyroglobulin was 11 about 3 months after radioactive iodine, and it's coming down to 3.2 now, 2 years later, almost 2 years later, in October 2021, trending all time to decrease, no thyroglobulin antibodies, clean ultrasound, pathology showed 15% tall cell variant. I think so. This is an exact situation where it sounds like you would be in that category of biochemical incomplete, since there's still a detectable thyroglobulin, but not showing any structural disease on, it sounds like on the imaging that you have a clean ultrasound. So nothing suspicious in the ultrasound. The radioactive iodine does work over time. So as long as the thyroglobulin is going down, I would just keep watching and monitoring and see see if the thyroglobulin continues to decrease. If at any point in time it starts to go up again, then it may be that you need a second dose of radioactive iodine or additional treatment. But I would say this is someone who's probably had a little bit of residual disease. The radioactive iodine was helpful in treating that disease, and it's getting better over time. And it takes time. Thyroid cancer grows slowly and it responds to treatment slowly. So you just have to be patient and continue to watch and monitor. But I would say that this is someone who's responding quite well to the treatments and heading in the right direction.
I have one that may be a little faster. A 52-year-old was asking about when she was diagnosed at 52 and something about some lymph nodes, but she thought she was a stage 1. And then when she turned 55, does she considered a stage 2 because of lymph node involvement?
Yeah, no. So the staging is based on at the time of diagnosis. So that your stage doesn't change because you get older. So no, so you're always going to be stage 1 because that's what you were at the time that you were diagnosed.
Can thyroid cancer spread throughout the body or just the thyroid? And what causes thyroid cancer? How does it become a cancer cell?
Yeah, so nobody knows what causes thyroid cancer. If we did, that would be great. thyroid cancer is something that happens. There are certain things that increase the risk of thyroid cancer, radiation exposure and things like that, but we don't really know exactly why some people get thyroid cancer. And thyroid cancer can spread to other parts of the body. It's very, very rare. Most thyroid cancer is in the thyroid itself. If it spreads, it typically first spreads locally to lymph nodes in the neck, so it's not uncommon to have lymph nodes at presentation or develop over time. About 40% of thyroid cancer patients will have lymph node metastasis at some point. It can spread to the lungs, it can spread to the bones, it can spread to other parts of the body, but that's very, very rare. And that's in that small group of patients, that high risk of recurrence, those ones who have structurally incomplete response to therapy. So those are the patients where it does spread to other parts of the body. So it's certainly something that can happen, although it's not something that happens common.
Is it unusual for a teen to take 2 to 3 years to reach an undetectable thyroglobulin?
I don't think for anybody. I don't think it's for anybody. It can take years. Everyone's a little different. Some people are undetectable at their first test. Some people, each time you measure it, it's lower and lower. It takes 2 to 3 years and it eventually goes away. So why? And again, I don't have a good answer. We don't know why, but that's something we certainly observe. But it doesn't, and it's not an indication of any worse prognosis or anything bad. It's just the behavior of that tumor and the behavior in that person's body. But as long as it's going down, it doesn't matter how long it takes.
This is a little different. Does TSH suppression cause weight gain? This person has a strong family history of diabetes and has been working on keeping weight down because of this.
So in general, I would say no. And if anything, so when your TSH is suppressed, it means you are a little bit hyperthyroid. Your thyroid levels are a little too high. The higher your thyroid hormone levels, the lower your TSH. So most typically with TSH suppression, it should rev up the metabolism a little bit. We generally don't see weight loss with that TSH suppression, but it should not be associated with weight gain. We see weight gain more typically with hypothyroidism, which would, with low thyroid hormone levels, which would be associated with a high TSH. It's not everybody. I think after thyroid surgery, some people do gain weight, but I don't think it's the TSH suppression that causes that.
Another quick question, to decrease the suppression, you would decrease the amount of medication, correct? She's asking.
That is correct. So so the low TSH, high thyroid hormone levels, if we don't want the TSH so low, we give a lower dose of levothyroxine or Synthroid, and that will allow the TSH to come up.
And what is the advantage of lessening TSH suppression over time?
So TSH suppression can cause other medical problems. It's a strain on the heart and can increase the risk for atrial fibrillation. So that's why someone who already has atrial fibrillation, we generally try to pull back on the TSH suppression. It can have effects on the bone and increase the risk for osteoporosis over time. So it's not complete, the risk is minimal, but it's not zero. And so if there's not really benefit to it, we do try not to keep that TSH suppressed over time, just to avoid some of these side effects that can happen. So the thing is that we don't see those side effects with a year of suppression, but we can start to see those side effects when we get to that 5 or 6 years of suppression. Then we can start to really see issues in the heart or with the bones. So that's why we try to pull back on that if there's no need for it.
Here's one. It says, once someone has been diagnosed with thyroid cancer, why do most doctors wait post-thyroidectomy to do a full body scan to see how much has spread? Seems like the full body scan can help to categorize it.
Yeah, so we don't really do, I will say that most of my patients with thyroid cancer, I never do a full body scan, a radioactive iodine full body scan. I only do it in my patients who I'm giving radioactive iodine to. Whole body scans are not the most sensitive test. And if a patient has a cancer that's not invasive, a low thyroglobulin level, the likelihood of there being any uptake on a whole body scan is quite low. And so it just doesn't give any additional information to help in the treatment. in those patients who we feel would benefit from radioactive iodine treatment, then we do a whole body scan or a post-treatment scan after the radioactive iodine. This is looking at the pattern of how the iodine's been taken up. We expect to see a little bit of uptake in the bed where the thyroid used to sit, but we scan the whole body as a way to double check to see if there's any signs of thyroid cancer anywhere else in the body. So we do that in the setting of, when it's someone with a little bit of a more aggressive cancer where we felt that there's reason or benefit to radioactive iodine, that's when we'll do a whole body scan. But in these smaller tumors, low risk tumors where radioactive iodine is not necessary, it's just not a necessary test. It doesn't provide any additional information that would have benefit.
What considerations are made for monitoring patients with a BRAF mutation?
So the BRAF mutation doesn't really, BRAF mutation is a mutation, BRAF V600E mutation is a mutation that can be seen in some of the more aggressive types of thyroid cancer. It's often seen in the tall cell variant of papillary thyroid cancer. But having that mutation really doesn't change how we monitor. That's not part of the decision tree in our monitoring. It really affects the pathology, and then that pathology affects how we monitor things. And so, if you have a BRAF mutation and you have a 1 centimeter tumor confined to the thyroid, that while you have that BRAF mutation, your tumor has not shown any aggressive behavior, so it wouldn't change my monitoring at all. If, on the other hand, you have a papillary thyroid cancer tall cell variant with vascular invasion and lymph node metastasis, and you have a BRAF mutation, well, I'm going to give you radioactive iodine after your surgery. That's really based on the fact of what I'm seeing your tumor behaving as, because I'm seeing the invasion into the bloodstream, I'm seeing the lymph node metastases. So the BRAF mutation can help to predict the behavior of a tumor, but it doesn't, it's not how we make our decisions as far as our monitoring and treatment.
This patient was diagnosed with papillary thyroid cancer at age 22 in June of 2021, received a total thyroidectomy in August, 1.3 by 1.9, papillary thyroid cancer, 3 of 4 lymph nodes removed, testing positive. Is there any way to do a full body scan or monitoring rather than RAI, concerned for the risk of fertility and secondary cancers?
I guess the general answer to that is no. I think, this is a situation where often one would recommend radioactive iodine. Nobody has to take radioactive iodine. Lots of people with thyroid cancer are monitored without radioactive iodine, even when it's recommended. So that's a personal decision. I think that in general with radioactive iodine, the effects on fertility in a young person are really minimal. In old women who are a little bit older, in like the 30 to 35 year range, when already there may be a little bit of a reduction in fertility, radioactive iodine may lower the fertility further, but that's not really seen in younger patients in their 20s, a significant reduction in fertility. And risks of secondary malignancy with a single dose of radioactive iodine is also quite limited and low. There's a slight increased risk of bone marrow cancers with radioactive iodine, but again, with a single dose, it's fairly small. But I think, certainly you have I think you always have the option to say you don't want that treatment that you had if you had surgery, and you just have surveillance with thyroglobulin and ultrasounds over time and are monitored without radioactive iodine treatment. That's certainly always an option. The treatment may be recommended, but it's a personal choice if you feel comfortable doing it.
Great. Well, we're down to just a couple of minutes. So Dr. Fish, we just wanted to thank you so much for your time and your willingness to answer all of the questions. And if you have any final remarks that you want to make, you can do that now.
I hope this was helpful to all of you. And I think this is such a great forum and a great program for the weekend. And I know there's still a lot of questions I didn't get to, but I think one of the good things, there's a lot of repetitive, some other people who will be speaking about similar things throughout the weekend, so that hopefully through all the talks this weekend, you'll get all of those questions answered. But it was really my honor to be here, and I'm really happy to have been invited. So I hope you all enjoy the weekend.
Thank you.
Thank you. Thanks, everyone.
Bye.